Right, thank you very much. Good evening, everybody, and welcome. This is the first of the Association of Surgeons of South Africa's ethics forums for the year. There should be 4 of them if all the plans work out. And we're glad to have you all on board. Welcome. I will introduce our speakers shortly, but you can see them on the screen there. I'm briefly going to unshare my screen and hand over to Michael Damant, who's going to give you a word or two from our sponsors, and then he will return to me and I will spend some time introducing our speakers and then hand over to them because they're the experts tonight and we want to benefit from their knowledge. Thank you, Michael.
Thanks, Prof. Hardcastle. Welcome everyone to tonight's event. My name is Michael Damant. I'm a director at Genoa Underwriting Managers. We are a liability UMA and we focus on professional indemnity for practitioners like yourself. Genoa has moved from strength to strength over the last few years and currently insure in excess of 6,000 medical practitioners across the country. These are everything from audiologists through to general surgeons, orthopedic surgeons and the like. And we are ecstatic this evening to be able to partner and sponsor this event with ASSA. It is a privilege to be amongst the likes of Dr. Boertes and Professor Thaldar. It is I'm sure everyone is waiting with bated breath to hear what they have to say. So toward the end of the session, our details will be popped up on the screen. For anyone who's interested in finding out a little bit more about Genoa and what it is that we offer, please take the time to click on the link and get in touch with us. So without further ado, I would like to hand back to Prof. Hardcastle and we really look forward to the talk that will follow.
Thank you very much, Michael. So without further ado, to briefly introduce our 2 guests this evening. Dr. Mariki Boertes is a lawyer with a master's in law in the field of commercial and property law, and she has a PhD in biotechnology law from UNISA. She's presently both attached to the University of KwaZulu-Natal and the University of Luxembourg in Europe as a postdoctoral research associate, and she's also an honorary research fellow at the School of Law. Importantly, she's a member of the Ethical, Legal and Social Issues Working Group in the Africa Biodiversity Pilot Program, and she was appointed by the National Research Foundation to the expert groups in the first and second edition of the COVID-19 country reports regarding the implementation of measures to manage, respond and combat the negative aspects of the pandemic in South Africa. So you can see already she has a lot of insight into these issues. Professor Donrick Thaldar is an advocate of the High Court who joined UKZN in 2017 and his interest is human rights litigation. He served with the Pretoria Bar, he presented at the Constitutional Court on a number of occasions, and prior to that, he was a biotechnology entrepreneur. So you can see the link with the biotechnology and therefore the understanding around the technology of vaccine and so on. His PhD in law is from the University of Cape Town, as well as a postgraduate diploma in strategy and innovation from Oxford. And importantly, he lectures in bioethics in the LLB program, and he coordinates the LLM, the Masters in Medical Law program. His interests obviously are in human rights. So clearly we have experts with us this evening, and I don't want to take any of their time up anymore, so I'm going to hand right over to them. I believe Donrick is going to start for us, and then we'll take it from there. Thank you very much again for your time. We appreciate it. I'm going to mute my mic and switch my camera off for the moment.
Thank you for the introduction, Professor Hardcastle, and it's an honor to be here with you and speak with you. I trust that we will be able to present you not just with a single approach or a single view on this matter, but with a bit of two perspectives on this, or at least two approaches on the question that we're investigating tonight. And perhaps we have the same end product at the end of the day. So let me share my screen. So I think just to begin, I want to take a step back and look a little bit at our culture and at the broader societal debate about COVID-19 vaccines, because we really need to take that into consideration when we answer the question of whether vaccination can be required for elective surgery. And over the past few weeks, we saw the so-called Freedom Convoy in Canada that was all over the news and led to a lot of debate, both in South Africa and I think all over the world. And South Africa never instituted vaccine mandates, although I think at a certain stage there was a real push from some ethicists to convince government to institute a vaccine mandate, at least within certain parameters. But then that never happened. And eventually the Omicron variant came along, and now in the latest State of the Nation address, the president indicated that the government will gradually start moving away from a state of disaster. So South Africa never went as far in terms of a mandate regarding the vaccine as did some other countries. However, we're part of a global village, and we're definitely affected by what happens all over the world. And in particular, in terms of the debate around the vaccine and whether one should be vaccinated, well, the whole debate surrounding that. And also the cultural reaction thereto, not only the reaction by the social media companies who might cancel this one and that one, but the general social reaction and the possible stigmatization of some individuals. So that's just my introductory statement of where I come from. So against that background, we often hear the narrative, freedom is not absolute, it can be limited. And this pandemic is supposed to be a good case to limit freedom. It is a public health issue, after all. Popular and ethical discourse often implicitly or explicitly makes vaccination a balancing exercise between freedom, personal freedom, and personal responsibility. These remarks assume certain value judgments. These value judgments include taking the vaccine is objectively the responsible thing to do, and the public good that is served by the vaccine outweighs personal freedom. These value judgments in turn assume certain scientific facts. These would include the vaccine has been properly tested and is safe and effective. And a vaccine can be developed and properly tested at warp speed, think Donald Trump, that is within less than a year. So let's recap before we go ahead. The debate about the COVID vaccine is often based on a narrative of freedom versus responsibility. And I've highlighted that this narrative rests on a number of value judgments, such as taking the vaccine is the responsible thing to do, and that these value judgments assume certain facts, such as the vaccine has been properly tested and is safe and effective. In an open society, if you want to make an argument that freedom, which is the default position, should be limited, you need to be willing to engage in open argument about your proposal and be willing to reply to arguments of those who oppose you. In other words, if others allege that the vaccine was not properly tested or is not safe, you need to reply by challenging their purported evidence and presenting evidence of your own. Freedom of expression is an essential truth-finding mechanism. However, what we experienced here in South Africa and in the rest of the world generally is that vaccine-hesitant voices and anti-vaccine voices were silenced, deplatformed, and cancelled from social media. In a democracy, bad speech should be countered with more speech, not with crackdown on speech. If people get the impression that freedom of expression of contrarian voices is stifled, they have good reason to mistrust the mainstream narrative. Why should the average person believe that the vaccine has been properly tested and is safe and effective? Whenever there were videos of doctors on YouTube who challenged the mainstream narrative, they were not answered with facts, they were deleted. This robbed people of the opportunity to be autonomous moral agents, to be able to make decisions for themselves after weighing the evidence for and against. Treating people as autonomous moral agents are fundamental to our constitutional dispensation. As the Supreme Court of Appeal held in the case of British American Tobacco, underlying all these constitutional rights is the constitutional celebration of the possibility of morally autonomous human beings independently able to form opinions and act on them. Whenever contrarian voices are repressed, whether by a government, big social media companies, or by social pressure, people are robbed from having the opportunity to listen to all sides and make up their own minds. Moreover, when contrarian voices are silenced, people become suspicious. In this light, let's consider the freedom versus responsibility narrative. Only an autonomous moral agent can act with responsibility, with true responsibility. If your ability to consider the truth and the good as an autonomous moral agent is systematically eroded by suppression of expression, it makes no sense to say that you must act responsibly. You have no way to know what is responsible, what is truly responsible, and what is not. So, the notion that freedom must be balanced with responsibility in the current atmosphere, in the current climate, makes no sense. At best, the elites can argue that they know best and that the people are ignorant and therefore that people must just do as they are told. This will be an honest argument in the current context, but of course, a paternalistic argument, and it would be antithetical to our constitutional order. Therefore, I suggest that the freedom versus responsibility narrative in the current social climate is misleading and should be avoided. So, against this background, in this light, we must realize that vaccine status is not merely a medical issue. It is now a political issue, and it is an issue of conscience to many people. This raises the question, can one discriminate based on conscience? As a general rule, no. In South Africa, individuals have free choice to decide whether or not to get the COVID-19 vaccine. If being vaccinated is set as a condition for accessing elective surgery, it will infringe this freedom and likely discriminate based on a person's own conscience. Are there reasons to justify such a limitation? I will consider two possible reasons. The first one, the right of healthcare personnel and other patients to decrease the chance of disease transmission. And secondly, increased health risk to the patient himself or herself. Let's look at the first one. There is a statutory duty on health establishments imposed by the National Health Act in Section 20 that provides that every health establishment must implement measures to minimize disease transmission. But does this require vaccination? Why not proof of the fact that the patient has recently been ill with COVID and therefore has natural immunity? Why not simply a COVID test before the elective surgery? Given that the vaccine is not fully effective against transmission, a COVID test seems to be a far more reliable way to minimize disease transmission. Furthermore, hospitals should implement measures such as the use of PPE, of course. Let's now consider the second possible reason, namely increased health risk to the patient himself or herself. This, I suggest, will only be relevant in a small number of cases. In most people, COVID-19 is not life-threatening. However, in old people and in people with comorbidities, COVID-19 can be life-threatening. This must be considered against the general state of the pandemic. Are we currently in a COVID wave, or are we in an interwave period? Risk is usually measured against two factors: the chance of the risk materializing and the impact of the risk if it materializes. If both of these factors are unfavorable, in other words, if the unvaccinated patient is part of a group for which COVID may be life-threatening, and if we are entering into a new COVID wave, I suggest that you would be justified in refusing elective surgery for such an unvaccinated patient. However, as we are currently in an interwave period, I suggest that there is currently no reason to refuse treatment to somebody who is not vaccinated. I suggest that currently this reason, namely protecting the health or the life of the patient himself or herself, is not significant enough to refuse elective surgery in the current state of affairs, where we are not currently within a COVID wave. So it follows that you should not even ask about your patient's vaccination status at this stage, as this should have no effect on whether you operate on your patient or how you treat your patient in the current context. If we enter a new COVID wave, this will change, of course, but it will only be relevant to patients who are in high risk groups, such as old people and people with comorbidities. If my teenage son, who is healthy, arrives at your practice for elective surgery, there is simply no reason to ask the very personal and potentially politically loaded and socially sensitive question, are you vaccinated? Thank you, colleagues. It's over to my colleague, Dr. Botha.
So thank you, Donny, for laying the regulatory framework for all of this. My approach would be a bit more on the ethics side and the refusal of medical treatment of unvaccinated, but in this narrative also of non-compliant patients. Now, I know it's not the direct topic of today's meeting, but it's important to have a look at the developments in the previous debates in this ethics sphere to understand the narrative and where it comes from. And I always, when I trained my candidate attorneys, I always told them to understand the law, then you know how to apply it. So the duty of care in times of risks, what is different? It seems like we have these ethics debates all over again, and it never stops, and we never seem to learn anything from them. So the past few decades, the discussions around ethics in this context was dominated by the duty to treat or not to treat HIV-positive patients. So that was the predominant talk for decades and decades. The emerging threats these days are serious infectious diseases, airborne infectious diseases, such as severe acute respiratory syndrome, SARS, drug-resistant tuberculosis, Ebola, and a human transmissible avian flu, and most recently also COVID-19. So when you have a look at the COVID-19 infections and all these airborne infectious diseases, and you look at the ethics debates as it developed with the treatment or the non-treatment of HIV-positive patients, you will see how narrow the ethical interpretation of the duty to care was in that context. And that's why I start with that aspect, and we will see how that developed forward, especially in the context of COVID-19. So what is different with infectious diseases? One of the most important aspects is the speed with which infectious diseases could spread. And this is shown in the COVID-19 pandemic that it could easily overwhelm and ultimately shut down entire healthcare systems in a way that AIDS never did or never could. And with airborne infectious diseases, this also includes the duty to work extended work hours. There's quarantines you need to deal with, there's speedy transmissions, and unlike AIDS, there's also rapid death. So this brings along with it physician, healthcare, burnout, which I don't need to tell medical practitioners about that, which puts an extra emotional layer into whether I have a duty or not to care, because you take, whether you want or not, you take emotional decisions when you're strained, when you're under pressure. In this context, the WHO estimated that between the period January 2020 and May 21st, there was almost a death of 115,000 deaths of medical practitioners or healthcare workers, which give you an indication of the loss of human resources in this context, which just adds to the extended work hours, the burnout, the speed, the overwhelmingness, the functionality of healthcare systems. So this is important to realize. This is the atmosphere or the environment within this pandemic played out, and why the ethics in this environment differs from the ethics from HIV, the previous ethics, and what we must learn from it. So now that we know the backdrop and the stage, so to speak, how does this affect surgeons specifically? So I'm going to talk a bit in the bigger picture, not specifically only limited to vaccinated or unvaccinated patients, but also to Non-compliant patients, patients that are drug abusers, alcohol abusers, obese patients, patients that does not stick to medical regimes, because the same ethical arguments that apply to those patients, many of those also applies to whether or not you should treat a vaccinated or an unvaccinated patient. And it's important to understand that mind frame to make decisions, and to make decisions where it's not black and white. So one of the biggest frustrations for surgeons and medical practitioners is a so-called non-compliant patient. This is when a patient receives very clear instructions, the patient acknowledges those instructions, but still fails to follow them, and then slips even to worse difficulty than he or she had before. For instance, a patient with a peripheral vascular disease who are in need of bypass operations find himself unable to stop smoking and therefore unlikely to gain durable benefit from the operation. Or when a patient who abuses drugs has an operation and then will not or cannot stop using drugs. So this can easily be extrapolated to unvaccinated patients that elect to undergo surgery. And whether or not you have a duty to actually do that surgery or not. So let's have a better look or a closer look at the nature of the duty to treat. So in virtue, this duty comes from our shared humanity. And the idea behind we have a moral duty to aid others who are in greater need than ourselves, and if and when we can do so at minimal risk to ourselves. Now, this degree of risk is very important, which I will explain now, because you're not expected to take on immense risk, not any risk. It says that you need to take on minimal risk to yourself at minimum. So this originated within the moral theory. Such duties are commonly known as general positive duties. Duties when you are obliged to do something, as opposed to negative duties, where you are supposed to not to do something, such as not to kill, or you are obliged not to do something that will do harm to another, typical like stipulated in the Hippocratical Oath. So the question is, will evil thrive if good men do nothing? If you do nothing, see nothing, will evil thrive? So positive duties to aid is evidenced by the moral outrage that occurs when people fail to fulfill them. Now, there's two classical and horrific cases that both happened in the US, where people failed to come to the aid of people with fatal consequences, and the moral outrage that followed actually translated into legislation at the end of the day. The first case is a fairly old case in 1964. It's the matter of Genovese, where 38 people heard or witnessed portions of her attack in a neighborhood, and she was ultimately murdered in an apartment square, and none of these people even notified authorities until it was too late. I think many of us think that I'm not going to do anything, I'm not going to get involved because someone else will take the initiative to contact the authorities, the police, the ambulance, or whatever. 38 people did nothing. So did evil thrive? Yes, it did. Then a more recent case, 1997, is the matter of David Cash, who did nothing to assist a little girl whom his friend assaulted and killed in a bathroom in a Las Vegas casino. After the murder, he merely walked away and proceeded with his gambling activities. Again, he was in a position to do nothing with minimal risk to himself and decided and chose to do nothing. So there was public outrage at these cases, and this outrage renewed the efforts in many US states specifically to impose criminal penalties on those who demonstrated gross failures to aid, thereby giving legal recognition to this general moral duty. So this is how moral duties and ethics translate ultimately into legislation. Many of these laws now exist in various forms in a handful of states in the United States, as well as in European countries. But for the discussion of our purposes today, it's important to note that nowhere in these laws are someone obliged as a mere bystander to take significant risks to aid another. The duty in these cases are limited to minimal risk at best. So what does this mean in a medical setup for a surgeon? Now, I call this the shark attack test. So the hallmark of positive duties is you need to come to the aid of someone with minimal risk to yourself. But the hallmark of special positive duties is the existence of a special relationship between the aider and aidee that grounds that duty. And this special relationships typically exist between a doctor and a patient. Doctor is not merely a bystander, he's a specially trained medical professional who gets into a specific relationship with the patient to come to the aid of the patient due to his training. So this can obligate people to incur greater risks than the mere positive duty to act. For instance, an on-duty lifeguard could be obliged to venture into a coastal riptide to rescue a swimmer. It's his or her job after all. Whereas a bystander on the beach would not have a parallel general positive duty to do so. But this duty, special relationship duty of the lifeguard, does not mean that the lifeguard is obligated to incur any and all degree of risk. He or she is not obligated to enter the surf to try to rescue a swimmer from the mouth of a great white shark. That would be unreasonable to expect that from even an on-duty lifeguard. So despite the special relationship that the doctor and patient find themselves in, you do not need to take on this overly unreasonable risk, which I call the shark attack test. So there may be conflict of duties as well. Sometimes this additional obligation is grounded in the presence of conflicting duties to others. An example is a paramedic who dies or is seriously injured while trying to aid others will not be available to continue aiding the many who may still be in need of his services. And in addition, that paramedic may also incur or need additional resources, which may even be diverted to himself. So this seems to be a conflict of duties. So special positive duties can oblige people to take on greater risks that would have been the case with a mere positive duty, which typically sees to be duties with a degree of risks in more than minimal, for instance, the lifeguard on duty, or the medical practitioner who needs to take on further risks as the mere bystander due to his training, the environment he finds himself in the special relationship with the patient. But the upper limits of that risk cannot be specified in the abstract. Among other things, the limit depends on the source of the duty, the relationship between the doctor and the patient, and what exactly is expected from the doctor in the presence of that conflicting duties. So, to stir a little bit of a debate, I will discuss some of the arguments I came across against treatment in this context, some of the arguments I came across for treatment, and then I'm going to conclude with what I think is the best way forward and conclude with very specific pointers for surgeons. And this is merely to stir debate. It's not reflective of my own personal opinions necessarily. So there are very literally reading of the Hippocratic Oath, where it says specifically, I will prescribe regimens for the good of my patients according to my ability and judgment, and never do harm to anyone. So some physicians say that they will do according to their judgment what they think is the best, whilst not doing harm to anyone. And that anyone can include his medical team, especially in a surgeon. Surgery does not happen in isolation. You're part of a team of nurses, theatre nurses, etc. So you may say that according to my judgment, I'm not taking on this risk. Even Illich wrote that classifying all the troubles of humanity as medical problems is actually antithetical to true health, in that it limits the ability of people to learn to cope with pain, sickness, and death as integral parts of life. So his theory was that people need to learn to live with the consequences of their lifestyle decisions, so to speak, And if that lifestyle decision includes, I will not or I will refuse to vaccinate myself, you need to live with the risk, the realization of that risk, the symptoms, the treatment, or whatnot, and the long-term consequences of falling sick. Or maybe you may refuse to be treated medically or operated on. So he continues to write, physicians should not fool themselves into thinking that all problems can and should be fixed. But this is not to say that one should never try. Health, he maintains, is not freedom from death, disease, unhappiness, and stress. These are inevitable if you are alive today, but rather the ability to cope with them competently. So from this philosophy, you can immediately see that he lessens the burden on a physician not to save humanity from itself or from life, so to speak, but to aid people in living life to the best of their abilities. So if this is true, then the more medicine and society direct individual behavior, the less autonomous and therefore the less healthy the individual may become. So this is one angle of arguing against treatment, and that putting control, so to speak, back to the patient as the patient wants, patient-centric regimes, that you need to take responsibility for your lifestyle choices, be it your drug, alcohol abuse, your obesity, your refusal to vaccinate yourself, and that you need to learn to live with that consequences. Continuing on arguments against treatment, this is a very old ethical argument. In 1974, Faith Fitzgerald wrote, and this is in context of social responsibility of medical practitioners, that in the 19th and early 20th century, so it's not that long ago, if a person fell ill, had alcoholism or tuberculosis, or abused a spouse or a child, they said it was a pity. But it was a pity for the person and a sadness for his or her family, and it was their business. Over the past several decades that followed, however, both the existence of these types of imperfections and the remedies for them have become society's business, particularly since society began to accept the responsibility to pay for these consequences in social grants, etc., of these imperfections. Now, treatment for drug addiction is a diagnosis, prevention of domestic violence, handgun control, and use of seatbelts and helmets are society's responsibility. So against this background, and now, because of these imperfections are unhealthy, it becomes the responsibility of doctors and nurses, and having a vested interest in certain forms of behavior, previously considered being a person's private business, now impacts the person's health, which ultimately becomes the practitioners, the healthcare system, the surgeon's business, as opposed to the private business. So you can see there was a shift in social responsibility due to social changes and as Donry alluded to it, political thinking behind it, that private business that causes weak health or health issues now became the issues of health practitioners, which may have an impact on whether or not practitioners want or wish to treat patients or not. Then again, as I said earlier, especially in surgery, it does not happen in isolation. There's always a team of highly skilled, specialized people involved. Unfortunately, few of the nurses, perfusionists, and anesthesiologists have the right or the ability to protest any decisions made by a surgeon who feels an obligation to help someone or not to help someone who fails to care for himself or who fails to undergo a vaccination. The question, however, is to what extent should a doctor risk his entire team? And Donry already alluded to the balancing of risks. And I come to that in Mill's utilitarian theory, where he speaks about the collective risk of harming many persons, shifts this equation to the greatest amount of good to the greatest number of people. So it boils down to a balancing of, do I benefit the greatest amount of people, or is the resources, time, energy, and possibly the futility of the treatment I'm doing for this patient harming the greater collective risk, especially considering the risk to my surgery team, my theatre team. So the spending time, energy, and resources are not limited to only one patient who has chosen to doing self-harm and doesn't serve the greater good. Although a surgeon might think he operates simply with a one-on-one relationship with a patient at a time, he may not deny the good of many others with such a narrow framework. So against this backdrop, many physicians say that I'm wasting my time, I'm risking too many lives, highly specialized, skilled lives. I am not going to take this risk, not for myself, my other patients, or my theatre staff. I'm concluding with arguments against treatment with the allocation of resources. Now, this, in contrast with first world countries, in South Africa is a very, very real problem. We often sit with double, triple, even quadruple disease burdens in heavily under-resourced, especially public healthcare facilities, who may or may not be able to handle surges of incoming patients during a pandemic. And it's not only during a pandemic, there's trauma patients coming in from road accidents, from violence, etc., etc. So many of the public hospitals simply do not have the resources. And as we've seen with so many deaths in the medical fraternity, these resources may even become less as the pandemic extends over time. So time is not unlimited for a surgeon. I don't need to tell that to the medical practitioners who felt the sting of burnout. You only have 24 hours in your day. But it's equally true for all the members of the operating care teams. I think everybody feels the same sting of being under-resourced, stretched, or spread too thin. If we do not begin to understand how to allocate these health resources more wisely, these health resources or the allocation will be forced upon us. And there's the very, very famous case of Subramuni, in which case the court determined that health resources can be applied to or allocated to serve the greater good and not necessarily to be allocated towards a patient with so many comorbidities or so many health issues that the allocation of the health resources, considering the availability thereof in a state setup, simply may not be worth it. So against this backdrop, and with all these arguments and nuances in between, many surgeons say that they simply do not have the obligation to treat his patient if he or she is a poor steward of his or her health. So that's the arguments against. So let's move forward to the arguments for treatment. And again, keep in mind that I do this against the backdrop also of drug addiction, which is, although it's a form almost of self-harm the patient brings upon him or herself, it's also a diagnosable disease that's complex, that happens over a long period of time with relapses that should be treated, but treated by multiple stakeholders, etc. So I liken this to a certain extent with most infectious diseases, which are also complex, but treatable. So it may have long chronic term consequences, as we now see with long COVID. It may have relapses, we don't know, we still investigate long COVID. And these diseases may require ongoing surveillance and possible repeated treatments, as we've seen with TB, for instance. So physicians involved in the care of these patients should also sought the expertise of other medical practitioners, especially if you look at this problem in the context of drug or alcohol addiction or obesity. You may incorporate practitioners such as psychiatrists, clinical psychologists, dietitians, addiction specialists, and more. So many of these patients need to be treated as dual diagnosis patients. And I'm sure the same is often also the case with someone that comes in for certain surgery, heart surgery, kidney surgery, whatever the surgery may be, with a risk of having COVID or comorbidities. So it may be dual diagnosis patients with a team of experts needing to look after that patient. Many patients suffering from various illnesses or interconnected illnesses may not be able to manage their entire treatment regime alone. So making certain demands on a patient as a condition for medical treatment is almost akin as to punish that patient. Some professionals may tend to be, or they tend to be omnipotent caretakers, but in the long term, they end up deluding themselves into believing that they can do it all. They should rarely do they ask for help from other professionals. And as we've seen in complex cases, especially in complex infectious disease environments or pandemics, where the nature, the degree, the spreadability, the long-term effects, etc., of these diseases such as COVID is not entirely sure, especially right at the beginning of the disease where so little was known about it, may be very, very complex, and it may be necessary to include other specialities as well. And some of the patient's problems may be completely unrelated to pandemic-related issues. And then in that case, you do not want to prohibit or prevent surgery from taking place duly because you cannot bridge the obstacle of a patient not being vaccinated. But again, it comes down to a balancing of risk, the nature, the degree, and the exposure to other people of the risk, and whether the possibility of it being materialized. So further arguments for treatment, or things that we've seen in South Africa, but especially in countries abroad as well, is so-called performance contracts, especially in the context of organ transplants, where physicians or medical practitioners demand from patients to demonstrate lifestyle changes to qualify for certain medical treatment, that the patient needs to drop some weight, to stop smoking, to stop drug abuse, alcohol abuse, whatever the case may be. And this is purely to prevent the need for emergency care without withholding essential care from other patients with similar medical problems. So again, it's this balancing of, do I allocate my time, energy, and resources to the greater good? Can I treat 10 other patients as opposed to going back to this non-compatible patient that is not valuing his or her own health? But the problem with these so-called performance contracts or demands is the legality of that contracts. Now, that's a debate and subject for a whole other webinar between the patients and the healthcare practitioners. Should that contracts be incorporated into medical practice? Because they could be fraught with ethical problems and potential legal consequences. And surgeons should provide treatment within the prevailing standard of care to patients, regardless of any contract of previous agreement. Should the patient not abide by these care guidelines and recommendations, despite the best efforts of healthcare providers, then ultimately, and karma has its way, the consequences are on the patient. And the other question is, could such a contract be enforceable in a court of law? For instance, if someone came to the emergency department with an urgent life-threatening medical condition, you are legally obliged, specifically in South Africa, to at least stabilize that patient and make it less life-threatening before transferring such a patient somewhere else. You cannot deny such a patient treatment. And if physicians fail to render such care on the basis of such a document, there could be significant risk of exposure to litigation for failure to render necessary care. So, as I said, performance contracts are there, they are happening, they're fraught with ethical and legal consequences. It's almost a debate for a whole other webinar. So those are the arguments for and against that's purely done for the stirring of a little debate. And I want to come to the following conclusion in the broad sense of non-compliant patients specifically. And I want to say that the primary obligation of physicians is to treat their patients, or is towards their patients, not to save resources, to save their team, to save themselves. Primary obligation is towards their patients. Their obligations to themselves, their institution, their colleagues, and even their society are secondary to this primary obligation. So considerations of the patient's well-being must come first. And something I didn't expand on, but for instance, which you get in the cases with drug abuse, for instance, and other non-compliant patients is, but they can be viewed as lower rung people or people with a lower rung in the social community. So their social worth is to such an extent determined that you do not look well after yourself. I will not treat you again. Your social worth is not to such an extent that I will waste resources on you. And it was especially exploited, the social class issues back in the 18th, 1900s. But social worth has no place in medical decision-making. As I said, your primary focus is on the treating of your patient. This became a crucial principle of medical ethics when the bottom of the slippery slope of social worth as an evaluative factor was reached, especially in Europe, also in the 1930s and 40s, which luckily changed over time. So the patient is doing this to himself. This is the argument for not being vaccinated. And therefore, he or she does not deserve an operation. This seems to be a moral judgment that we, or you as surgeons or physicians are making, but should not be in a position to make. You see human frailty in action every day. If it wasn't for human frailty, stupid decisions people make, they will not end up in emergency rooms, in doctors' clinical rooms, and they will not need operations, treatment, etc. So we cannot really make that moral judgment about someone's harm or not harm they do to themselves. People engage repeatedly in risky activities with a high probability of damaging themselves. They ride motorcycles. You get your weekend warriors with mountain biking accidents, I'm sure, on Monday mornings on a regular basis. You get people that eat too many saturated fats. They continue to smoke. So these are all self-harm activities which society approves of. So we may disapprove of their activities or their habits, but when they return to doctors, doctors may, and I can imagine why, become frustrated with the reappearance of these old behaviors and how that impacts on their health. But a doctor is still obliged to care for that patient without hesitation, because his obligation is with the patient first and foremost. Stewardship of surgeons must be directed primarily to preserving the well-being of patients, not healthcare resources or the well-being of society. Not that that is to be ignored, but it must definitely be secondary to your primary obligation. So if we translate this entire debate around ethics to elective surgery specifically, there's a commonly held view in literature that patients scheduled for elective and non-emergency, emergency surgery, different story, should receive the COVID-19 vaccine before undergoing any procedure. The idea behind it is this may decrease the chances of contracting the virus, transmitting the virus to others, and lessening the risk of complications associated with COVID-19. It's just interesting to note that nobody ever asked a patient, definitely not me, prior to an operation, did you undergo your flu vaccination? And I understand flu and COVID is not really comparable to one another, but still there's so many other transmittable or infectious diseases which you are not required to be vaccinated again or tested for before you undergo surgery. The Society for Vascular Surgeons provided that procedures for certain minimal life-threatening conditions must proceed, and all probability proceed on the basis of being an emergency, which you cannot refuse a patient, despite the COVID-19 risk and the risk to vascular surgeons. So again, if you think about the weighing of risk, the life-saving necessity of the surgery, as opposed to the risk to vascular surgeons, may outweigh the necessity of the surgery. And again, the vascular surgeons, the theater personnel, all those people should hopefully also be vaccinated to protect themselves against possible infection. or becoming sick to lessen the symptoms. But the Society for Vascular Surgeons also recommend that less severe procedures be cancelled. And they say in the same breath, but these procedures cannot be delayed indefinitely. A patient may survive, but he may suffer pain and consequences. And surgeons need to make decisions based on patients' conditions and risk despite the pandemic. Again, your focus lies predominantly with the treatment of your patient, which includes the treatment of the well-being of your patient. So the American Society of Anesthesiologists advises to wait at least 2 weeks after patients' final vaccine dose before undergoing surgery. This is to obtain optimal defenses against the surgery and for side effects to lessen, to ensure that they're fully protected. Prior to vaccines, at the stage where we didn't have any vaccines, the common practice in hospitals was to have patients tested for COVID-19 before undergoing elective surgery. The COVID-19 vaccine has shown to be effective in reducing risk, but the advice would be not to rely completely on the vaccination of patients because it's not foolproof for elective surgeries and disregard established safety protocols, but to rather strengthening the existing pathways that allow operations to continue safely. That's more important than full reliance on vaccine data. At this point in time, we are lucky that there are many vaccines to choose from. You can test with fair certainty whether a person is COVID-19 positive or not. So there are options you can use to weigh the risk, whether it's worth it or too risky to proceed with elective surgery or not. Just for interest's sake, and I always say, especially when you have a debate about ethics, it's always worthy to have a look at history and what they decided then and whether how it could or could not play out in the future. So historically, epidemics have not been met with the expectation that all doctors serve equally, but with the financing of what they called so-called cadres of plague doctors, or with the exploitation of existing pools of military medical personnel. This was specifically true in the 1918 flu epidemic after the First World War, who are habituated to following orders and accepting risks. So that was one of the solutions they had back then. COVID-19 management has focused on the needs for first responders, the allocation of scarce resources, such as vaccines, ventilators, PPE, etc., and the movement of needed equipment. Less attention, unfortunately, has been paid to addressing the kinds of staffing needs that would be generated by ongoing multiple wave disasters of the sort that a serious infectious disease pandemic would create. Hence the fear and the discussions we now have about the safety of the burnt out, overburdened, and the remaining medical practitioners and healthcare workers we have. Along with addressing the other aspects of disaster planning, society should also direct significant attention to bringing more necessary healthcare workers under the umbrella of contract-based consent. For instance, you hire people to come in specifically to aid and to help in an area with an epidemic, pandemic, different story, to aid on a contract-based consent where they accept a greater risk if they consent to it. It's voluntary after all, to do their work in such environments. So thank you for listening, and I hope to have some lively debate in this regard. Thank you.
Well, thank you very much. I'm just going to share my screen again for us to have the important slide up, which follows there, because we are now open for discussion, and I'm sure there will be some discussion that comes through. I remind you that the Q&A function which we have here is the chat. If you have questions, please put your questions in the chat, or if you have comments. But I'm sure Donrick would also like to add some closing comments before
Yes,
we open the floor?
I can. As you see, Professor Hardcastle, we the speakers planned our presentations to use exactly an hour. No, I think just to start the conversation, and I think my colleague Dr. Botha would agree. In Dr. Botha's talk, she referred to the guidance by some of the professional bodies related to our topic. And I think all of that is of course correct and perfectly researched. My concern with that is just that, to the best of my knowledge, those recommendations were provided during 2021 and often in the early half of 2021. So that raises the question in my mind of whether those recommendations by those professional bodies, whether we can actually still rely on them. Now, at the beginning of 2022, where we know that our government is even contemplating moving out of a state of disaster, where we know that we are not currently in a wave, and where we also know that the current variant of COVID is Omicron, which is far less, let's call it hazardous, than the previous version. So Dr. Botha, I'm sure you'll agree with me that we've come a long way, and that although we can have regard to those, I think we must see those recommendations in the context in which they were provided. And absolutely. I think we must really confront the reality that we are now in a different reality, and that we need to adapt. And we cannot always wait for those professional associations to catch up. Typically with this, well, it's the same with the law. As lawyers, we know it, the law is typically a step or two behind the latest developments, you know. I suggest we should rather apply our own minds to the current reality. And perhaps I can ask Dr. Botha to respond. I think my conclusion was that we must measure risk on, let's call it, two axes: the chance of the risk materializing, and then what would be the impact. So in terms of chance, we look at whether we're in a wave or not. Currently, we're not. If we're in a wave again, then of course that will change. And on the other axis would then be, well, what would be the impact? And to recycle my example of my teenage son who is healthy, you know, for him there will never be a big impact, even if there's a wave. He's had COVID, it wasn't very bad for him. But on the other hand, for somebody like my mother, it will be, the impact will potentially be great. So the model that I suggest is, if we're in a wave and there is the possibility of a high impact to an individual, then I would suggest a surgeon is justified to say, well, sir, ma'am, you need to be vaccinated. But if any one of those factors are not unfavorable, then I would suggest that is then not justifiable. What would be your opinion on that? Do you think this is reasonable?
Yes, absolutely. No,
sorry, maybe before Mariki answers, there's a question that I think has come on the chat that almost leads into this: is there ever a time the vaccinations may become a public health imperative? I think that's kind of what you're alluding to, Donrick. Maybe Mariki, you can.
That's a different question, whether it's a public health imperative.
Yes. But it speaks to this question, to the point that any pandemic, especially with a new infectious disease like COVID right at the beginning, where you don't know the characteristics, you don't know how it will develop, how it would spread, how soon you will develop vaccines, treatments even. You work with a moving target. So guidelines need to move with the target. So I agree that even the best made guidelines right at the beginning may be outdated 2, 3, 6 months, especially guidelines made early 2021 may be completely outdated now. So that's why it's very important for me to have these conversations with surgeons, medical practitioners, to help them understand the reasoning behind ethics. Not, can I do this, can I not do this? It's not a tick box exercise. It's a weighing exercise, and especially for medical practitioners concerned about, in a country like South Africa with a very high probability of being litigated against and protecting yourself against litigation, etc., where you need to be able to weigh or informed weigh your position and the risks, like you say, and I completely agree with your model and the axis you used for that. Weigh the risk, and when you make a decision, to motivate it correctly so that you can do the right thing for the patient and simultaneously also for your team. And I know I said in my presentation that your primary focus lies with the patient and your secondary focus with the resources, with the team and yourself. But if you take the resources, team and yourself out of the equation, you cannot help the patient. So it comes in second, but short second. So it's very difficult balancing acts to strike. And as we know, facts are stranger than fiction. Patients hardly ever come in with a simple, just a plain, uncomplicated operation. There's always something that this patient is a little bit of that, a little bit of that. So it's difficult, and there's always time pressures, always under-resourced, always time pressures. So you need to make a decision. What is now more easy, or make that balancing act much easier, is you have vaccines, you have tests. There's even effective treatments that's coming through the ranks for COVID specifically. So there are, Omicron is not as aggressive as Delta, for instance. So there are factors that may convince a surgeon to push through surgery regardless of these COVID's environment present, as opposed to right at the beginning of the pandemic, where you've got no idea, there's no vaccines, no treatment, very aggressive symptoms, people are dying, there's not enough ventilators. Even for your surgery, you need a ventilator, possibly need a ventilator, but all the ventilators are taken over the COVID patients. So there was so much more risk, so much more to consider, which I think is now much more easier. But the goalposts changes. So you need to change the weighing of that risk as you proceed through a pandemic.
Good, thank you very much. I mean, it's interesting the way you both have addressed that, because the first of the big COVID surge studies made that similar recommendation that elective surgery can be safely postponed, especially if the patient is recovering from or suffering from COVID, but no more than 7 weeks. Then the risk to the patient outweighs the benefit of waiting. Which is an interesting finding and sort of a parallel to what you guys are saying. Right, I don't see any more other questions in the chat, and it is almost 7:10.
I can say something in conclusion if you wish.
Absolutely, and then I will move to my next slide. And
Mariki is then, of course, also welcome to reply. I think because you mentioned the question, and I think you wanted us to integrate it, and it was something to do with public health. So yeah. I would say, well, of course, COVID-19 is a public health issue, but the problem is just, it is not only a public health issue, it has also become a cultural issue. Just think of wearing masks and the whole culture regarding that in different subcultures, different socioeconomic groups, different geographies in our country. How is it being perceived, whether it's practiced, whether it's not, whether it's expected, whether it's not. So it's become a cultural issue, social, but also a political issue. The vaccines especially. So we as lawyers would typically view it through a legal lens. You as our medical colleagues would often view it through a medical or a public health lens. But we must always remember that something like this has long ceased to be one-dimensional. It is multidimensional. For instance, our economist friends would hammer on the economic aspects of lockdowns and everything like that. So we must just always understand that there's more to it than just one dimension, or the dimension that our profession might typically view it through, especially for that individual that we're working with. Mariki, I don't know if you want to add anything to that.
Absolutely. And two things on that level. On a local level, it was an immense stress test for a healthcare system to show weaknesses in the infrastructure, how you plan your practice, etc., which under normal circumstances, you will never do a stress test like this because it would be detrimental to everybody. And on a global scale, it's definitely a political minefield, not only with the vaccinations, the acquisition of PPE, the help and the speed of help that was provided between countries. So you could see the power play between countries on a global level played out. And I think this is a perfect opportunity for South Africa to position itself better, to fill up the cracks in the systems and to make the infrastructure better. How to do that in limited resources is a challenge, which I'm glad I'm not taking the reins of that. But it's definitely an eye-opening event to see where we need to shape up to make life better for our medical practitioners, healthcare workers, as well as our patients.
Right, so with that, and the slide up there gives you the contact details for Michael de Mont, so that if any of the attendees would like to make contact with him and find out what they offer. Without further ado, it then brings to the closure of this meeting, and I can only say a huge thank you to both Mariki and Donrick. This has been very interesting. I've loved the arguments this way and that way, and I mean that's what makes law so interesting as well, is there's again no real absolutes, are there? I mean, yeah, life and death is an absolute, but other than that, there's so many things that we can look at from different perspectives, and thank you very much for sharing those perspectives with us. And thank you to our audience. We had just over 30 people present, and I see there's a comment in the chat, somebody else saying thank you for the insights. So that brings us to the end of tonight, and thank you very much, and rest well and take on your patients again with renewed vigor in the morning.
Indeed.
Goodbye.
Thank you, everybody. Thank you.
That's great.
Bye-bye.
Thank you so much.